Hello, everyone. My name is Kimara Ellefson. I am the National Director of Strategy and Partnerships for the Kern National Network for Flourishing in Medicine, or the KNN. Welcome, all of you, to our third session in the series Foundations for Flourishing, which focuses this month on cultivating practical wisdom. Today, we are so fortunate to have with us two scholars and leaders who have literally written the book, or more accurately, books, on this very topic. To include, among many other works, they are co-authors of Phronesis in Medical Practice, The Will and the Skill Needed to Do the Right Thing. Before we introduce our speakers, I want to provide some brief background on the KNN and the framework that undergirds both our work and the focus of our session today. The KNN is a national movement that seeks to bring together those who believe that integrating character, caring, and practical wisdom throughout the profession of medicine offers a path to promote flourishing for all. Every one of us has something to contribute to this movement, to the effort of advancing flourishing. And while the field of medicine involves very real systemic and structural factors that impact each of us, we believe that we are agents within those same systems and can work towards shifting organizational cultures and mindsets together. We're stronger together. And that's why our theory of change emphasizes ways to connect, convene, and catalyze efforts that influence the culture of medicine towards flourishing. So as you've just heard, we believe in the strength of flourishing as the aspirational aim of the profession of medicine. Why flourishing? Well, I'd like to take just a moment to touch on that concept and how we see character caring and practical wisdom contributing to the advancement of flourishing for all. The KNN defines flourishing as a wholeness of being and doing, realizing one's own potential and helping others to do the same. We believe it can be measured across domains of happiness, life satisfaction, physical and mental health, meaning, and relationships, and is most commonly achieved through pathways of family, work, education, and spiritual community. While we very much need and believe in the efforts focused on wellness and well-being, we also see that flourishing offers a more holistic approach, one that is deeply grounded in community, in connection with others, and one that seeks to integrate the multiple and varied facets of our lives. In the KNN framework for flourishing, we've chosen a tree to represent that overall concept, reflecting the organic, ever-evolving nature of flourishing and its focus on continued growth and development. The trunk and the branches show that the interrelated elements of character, caring, and practical wisdom work together towards flourishing. Although the diagram only has room for one tree, we do firmly believe that we exist in a larger context that could be viewed as a forest. And so the blue concentric rings show for us an ecological approach, recognizing that these concepts operate within multiple levels, from individual to individual, within organizations, and within our society at large. Now, you may have noticed that in the diagram, practical wisdom is depicted as the branches that connect or unify character and caring. And that's because practical wisdom, we believe, has a unique role to play in facilitating flourishing. Practical wisdom, sometimes called phronesis, serves as an integrative virtue or function, helping us deliberate effectively and discern the best path forward when different values or virtues that we hold conflict. We believe that phronesis, or practical wisdom, is vital for navigating difficult scenarios and ethical questions, both generally and within medicine specifically. Developing practical wisdom enables us to blend experience, reflection, and judgment to calibrate our response and act in a way that promotes flourishing. When we met with our speakers to prepare for this session, I was struck by how they described practical wisdom as a way of moving through the world, a lifelong pursuit. And that means wisdom is not something that you have or don't have. There's not a moment in which one is wholly wise or wholly unwise. It does not offer us a single fixed answer, but rather encourages for each one of us an ongoing practice of questioning and reflecting. Am I acting more wisely today than I did yesterday? Today, we're honored to have two incredible individuals here to help us think through how to foster the strengths and skills needed to develop practical wisdom and systemic approaches to shaping healthcare settings that encourage clinicians to exercise practical wisdom. And so I am thrilled to introduce our speakers for this afternoon's event. First, we have Peggy Plews-Ogan. Peggy is the Bernard B. and Annie E. Brody Professor of Medicine at the University of Virginia School of Medicine and the co-director of the Wisdom and Wellbeing Program, a health system initiative to address stress, burnout, and professionalism at UVA, which includes a coaching program for both faculty and staff. Kenneth Sharpe is a professor emeritus of political science at Swarthmore College, where he taught political philosophy, practical ethics, Latin American politics, and foreign policy. Ken is also the co-author of the book Practical Wisdom, on which much of the work of the KNN is based. Thank you both so much for being here with us this afternoon to share your perspectives. To reflect the practice of practical wisdom, we've decided to structure this session as a facilitated dialogue, and we've also intentionally decided to refer to each other by first name, which you may have noticed during my introduction. We're going to spend some time exploring foundational questions on practical wisdom, and we also want to include your questions and your wonderings. So do feel free to submit questions or thoughts in the chat as they come to mind, and we will work to integrate them into the discussion. So just to be clear, we are not going to pause for a Q&A time at the end, but rather are looking forward to integrating your inquiries and wonderings into our conversation throughout. So please, as thoughts strike you, add them into the chat. So to get us started, I'd like to invite our speakers to share just a bit about themselves and what practical wisdom means to each of them. Peggy, would you start us off?
Thank you. And just thank you to everyone for being here. I respect the effort it takes to come to these kinds of things, and we're very honored. And thanks for the invitation. So if you pose the question, what does practical wisdom mean to me, or does it mean in my life? What I would say is it means getting up every morning and wondering throughout the day, was that wise what I just did? Mm. It's a constant commitment to trying to be the best person I can be, which is, I can tell you, I do not achieve on a daily basis. So it's a practice that there are good days and bad days, and forward and backward movement. So to me, it's just a lifelong challenge.
Thank you, Peggy.
I would underline that too, except I'm usually not thinking about it in the moment. I'm usually thinking about it in the evening or at night as I reflect back on the day in terms of how it was that I handled a particular kind of choice. And I think it's made me much more open than I was as a younger person to living with the inevitability of ambiguity and contradiction and difficult choice. Mm-hmm. The fact that there isn't, for many issues, there isn't simply a right and wrong answer. And that whatever answer I come up with may actually change because of the circumstances change. So when I'm in the classroom teaching, I'm constantly having to figure out not only who to call on and in what order and what to follow up on and who I should challenge and who I shouldn't challenge and in what tone of voice I should do that and who I should ask to see afterwards and whether or not I've structured things correctly, then I have to kind of integrate that and figure out, okay, well, what did I learn? As opposed to justifying or hiding from myself the mistakes that I made, I actually need to face up to them. That was something I always had a hard time doing, I think, as a younger scholar and teacher, and I'm mildly better at doing it now.
Thanks to both of you. As I've spent time with you, I will often now tell the story about how I have a Post-it note that sits on my computer that says, am I wiser? And then I have another one that says, was that wise? In an attempt to, I suppose, just trigger or get that habit, right, working in my mind to reflect that. And I hear in what both of you are saying, the complexity of this thing called practical wisdom. It's not just what we say, it's the tone of the voice that we use, it's the level of reflection, it's the humility with which we're willing to approach ourselves, and then think about integrating that. And so, in your book and in conversations with you, I've often heard you talk about the fact that virtues or character traits are really critical to exercising practical wisdom. And of course, we have character as one of the elements of our framework, along with practical wisdom. I'm curious how you believe that those can be learned in medical school, or what practices or exercises encourage that type of learning. So how do we foster this, in other words, in medical students and in medical school?
You want to take a first crack or you want me to?
Okay, I'll take just a first crack.
Okay.
I should first say that character traits or virtues was also not a concept that was meaningful to me until I got a bit older and more experienced. They were words that always sounded very preachy to some extent to me, and I didn't quite understand their importance until I realized how much of what I do just in everyday work with others, particularly as a teacher, involves things not well. Let me drop back. When I would hear some of the character words like courage or compassion or caring or empathy or resilience or patience or empathy, I had this misguided notion that they were a thing that you had or you didn't have, right? And it was only as I delved deeper into thinking about practical wisdom that I realized that those character traits were critical as kind of they weren't like here, let me put it this way. Character traits weren't just a checklist of values. And I think I confused values and character traits. And the character traits were critical because they were the kinds of things that motivated you to do the right thing. Right? They motivated you, they didn't necessarily tell you what it was, but unless you actually had those traits and had learned those traits, that they were kind of part of who you were, that any discussion of practical wisdom was really meaningless, because practical wisdom really is the ability to have not only those character traits, but the kinds of skills that you actually need to exercise them. Skills like the ability to reflect, the ability to deliberate, the ability to admit and analyze the mistakes that you make, the ability to listen carefully. So things, and those were actually skills, things like reflection and deliberation. And then I put those two together in my mind that it actually takes courage to actually reflect on what your mistakes are and to figure out what you're going to do next, for example. So that there was a kind of unity between having these virtues or character traits, having the skills like the ability to reflect and to deliberate, and the courage, a character trait, to admit that you were wrong, and then to figure out, which is kind of a skill, why that happened and what you would do the next time, which was a reflection. So somehow these abstract words, which I often would use in my teaching, they didn't have the actual meaning they came to have when I realized that all the decisions that I was taking actually demanded both having those kinds of traits and having certain kinds of skills. And finally, and this is one of the most important things I think for both Peggy and I, that it's the courage to deliberate and reflect on how you screwed up that actually teaches you the kind of judgment you need to exercise those kinds of character traits better the next time through. So it's kind of an ongoing practice. And suddenly these words, which were kind of abstract philosophical concepts, came to mean so much more to me. And my final thought there is, it was in the work that I did with Peggy and with others like my colleague Barry Schwartz in studying the professions, medicine being a key one of those professions, that I realized how it is that at the core of being a professional is to have those character traits and those moral skills so that you can actually make decisions in situations that are uncertain and ambiguous and in which you don't have all the facts, in which there's no clear answer. And the good professionals actually do that all the time. And that's what led to the collaboration with Peggy, which was, how do you actually design structures in the classroom, in colleges, in medical schools, in clerkships and internships? How do you actually design structures that encourage the practitioners to learn those kinds of things? How do you design? And I think one thing that was been crucial for both Peggy and I is it isn't just telling people about them. It isn't lecturing people about them. It isn't having a list of things that people memorize. It's how you design things so people practice, make mistakes, and learn through that practice to get those skills and that judgment to be wise. That's a process for me, and I think I'd like to think that we have something to say now to encourage others not to have to wait until they get to the age that I was, where I figured those things out.
Thanks, Ken. Peggy, what are some of those practices that you and Ken have written about and have discovered?
So I wanted to add to what Ken said, which is
Please.
one of the things I realized was that no matter how much I perhaps knew the right thing to do, actually doing the right thing in highly challenging circumstances is a whole different story. And so I started thinking about practical wisdom as with sort of this, there are some fundamental building blocks, if you will. And, some of them start with the fundamental desires or will that maybe, who knows, you got from watching your parent be a compassionate physician or, some other thing that has added to your desire to do the right thing, to be compassionate, let's say. But we get in our way by a lack of certain capacities, the capacity for self-awareness, for self-regulation, for perspective taking. And each of these then feeds back into the virtues in a kind of beautiful way. Think about perspective taking. So you could think about perspective taking as a skill, right? But when you can take the perspective of another your compassion actually grows. Your capacity for compassion actually grows. And the next time that a challenging thing comes along, you have more capacity because you've practiced that over time. So it's a very circular thing that drives me insane if I think too much about it. But I do think about kind of the fundamentals as being things like building this capacity for self-awareness, for self-regulation, for perspective taking. Cognitive flexibility is another one. Have I changed my mind today is another one of my, my capacity builders. For perspective taking, I wonder is a simple question to put in your back pocket and carry it around with you. And when you get into a situation that, kind of brings you up short, to be able to stop and ask that question. I wonder why Ken did that. I know him to be a good person. Let me ask. Or maybe I don't know him at all. But that I wonder question is one of these fundamental capacity builders, I think. We teach early in medical school, we teach the STOP technique, which is a very simple. STOP stands, so STOP, right? It stands for stop, that's the S. Take a breath. And there's all kinds of reasons, of course, why you take a breath, right? Anybody who's done mindfulness or whatever. The O stands for observe. Okay, what am I thinking? I'm thinking he's a jerk. Okay. What am I feeling? I'm mad. Okay, good to know. You've taken a pause there, and by just that virtue of the pause and observing, what am I thinking? What am I feeling? You're building self-awareness. You're starting to build self-regulation because now you've expanded your capacity for choice. Well, I could, be mad and say something awful to him, or I could ask a question. I wonder why. And then the P is proceed with awareness. Okay, here's what I'm thinking and feeling. Here's the situation, and here are my choices. That builds curiosity. Just that ability to stop, take a moment, and ask the curious question. I wonder. Building this capacity for reflection starts with: was that wise what I did now, or this morning? This stash of positive emotion that we can build also, I think, gives us a platform for acting wisely in really challenging situations. If I fill my life with gratitude for simple things, with gratitude for the way someone has treated me this morning, I am more likely to be able to respond with compassion earlier in the afternoon, if you know what I mean. So that however we can build positive emotion is another way of building these fundamentals. And of course, that there are many ways to do that. Gratitude practices, appreciative gossip, there are hundreds of ways you can think of to do that. And to me, you're filling your tank with enough positive emotion that you can get to a point where you can respond wisely in a really challenging, what feels like a very negative situation. So I kind of rifled through a lot of this, but I hope that's helpful.
We started by talking a little bit about this idea of virtues or character traits and how practical wisdom is rooted in that. One of the participants is I guess kind of asking that, right? Is practical wisdom rooted in ethics and virtues? And are there cultural differences then in what is considered ethical and virtuous, and how might that impact the contexts in which we are exhibiting practical wisdom or working on this concept of phronesis?
I'm going to have a very simple answer to that.
Yes.
Yes. And as a doctor, I'm kind of outcomes driven. That if what I said or did or the assumptions I made did not have a positive outcome, or the outcome I hoped for, any human would hope for, then I need to rethink it. So rather than coming from I guess it's what Ken was saying, that if you're open to constantly saying, was that wise what I just did, then you're open to cultural context that you don't yet understand. If you have curiosity and humility, you're going to approach a situation with enough of that, hopefully, that that context can become, central to a decision you make in a particular time for a particular person.
So that Peggy's part of one question that what Peggy is saying raises for us is it's not enough to simply tell our students or colleagues what Peggy just said, have them kind of write it down and do it. The real difficulty that we face is in the institutions that we work in, certainly in medical school and in other professions too, is how do you actually design systems or design structures which kind of encourage people to have the practice of doing what Peggy just said every day, as opposed to just having their either clamming up because they're fearful, faking it because they want the senior resident to think that they understood, knowing when to take a sip of coffee at the right time when you're about to be asked a tough question when you're doing rounds. Instead of seeing this as an antagonistic relationship, to see it as an ongoing learning through mistakes.
Mm-hmm.
That's certainly going to take courage to do, but it also takes kind of elders, teachers, to encourage those kinds of practices, whether it's in the classroom, in the clerkship program, in the medical institution. And it's that design element, which we'll come back, I think, hopefully, and talk about it later. But it's not just on the individual to hear what Peggy and I have to say and decide to be like that. It's on the institution to figure out what practices will teach people how to be like that in their everyday work in the medical profession.
The other thing this question brings to my mind is that in medicine, as in, I think, other professions, we're often preoccupied with being right. And then, you hit real practice and you realize that right isn't so easy to come by. And it's very contextual. And that ambiguity drives some people crazy because they want to be right. And you do want the best outcome for a patient. And you often don't know the right thing, from the beginning. So a lot of humility and willingness to get in there with the ambiguity, acknowledge it openly, and then be watchful as things develop. I think that's true in medicine with caring for a patient. I think it's true in relationship with a patient or with a colleague. And our preoccupation with being right, particularly when we're dealing with colleagues or even patients, can get in the way of us noticing that actually this is kind of an ambiguous situation. So whenever I think I'm right, that to me is a big red flashing light, because I've been wrong too many times. And that does come with age, I think.
So speaking of age, one of the questions that was raised, and Ken, I'm thinking about how you set it up, where you maybe wish you would have grasped some of these concepts earlier. and are hoping now that you could. There is sometimes this debate about whether or not practical wisdom is only gained through experience, or or whether or not maybe it's does age matter? Does the amount of life I've lived, the amount of lived experience matter in terms of this acquisition of practical wisdom? And I think it matters as we look at our first year learners that might be coming in, and also for ourselves, does it look different at different life stages? Does a medical student just coming in have any practical wisdom at all? Maybe address some of those things that we hear.
Yeah, it's absolutely different at different life stages, because it is something that is learned through experience.
Mm.
And then the question is, what kind of experiences are we designing with our students? The way just the simple thing about the way we'll ask a question to a student in the classroom. And do you say, that's wrong? Does someone have a better answer? Or what's wrong with what so and so said? Or if you ask, take us through the thought process that got you to that.
Mm.
What would make you think differently? Can other people think of other ways that they might approach this, as opposed to you're wrong, be quiet? Actually, the very way that we approach our interaction with our students, and the tone, and even the tone of voice that we use. There's a great story. I'm sure everybody that's listening in has these stories from their own practice, but this was a story that I remember from a doctor at NYU, Jerome Lowenstein, who's actually, he works with students in the clinic, and he's also teaching an ethics class to his students, and he's talking about empathy. And he actually asks the seminar students, do you think we can teach you compassion in this kind of humanities course that he's given, not in doing rounds? And there's this really uncomfortable silence, and one student speaks up and says, I don't know if you can teach compassion, but you can surely teach the opposite. And Lowenstein says just what the student meant was that there was a total disconnect between the humanities stuff he was teaching in the classroom and how he and others were actually practicing when doing rounds with the students, and the fact that there was barely enough time to visit and care for the patient, let alone teach the students who were shadowing him. So he didn't really get the way that the things that he thought were important in the humanities part of the medical program were being undercut by exactly the kinds of ways that he and others were practicing when they were doing rounds. Right? So each of the instances of the practice, whether it's in the classroom, whether it's in the clerkship program, whether it's doing rounds, those are all opportunities that, if they're designed correctly, can create the kind of positive inquiry, the curiosity, the openness, the reflectiveness, the courage to speak that Peggy was talking about. But they need to be designed to do that. And the teachers also need to learn how to do that. There's nothing in their education that would necessarily teach them how to teach like that, unless they were involved with other teachers in observing each other in a certain kind of reflective practice. But having teachers observe each other and actually get them to think out loud with each other is so threatening in most situations that you wouldn't do it. But it's threatening because of the design of the institution. You could redesign things so that that actual act of reflecting on your teaching with others would not just be part of a checklist of things about whether you'd be promoted and get a higher salary, but would be something that your community does. And later on, if we want, we can actually talk about some examples of, I think, of medical institutions that have actually, or parts of them that actually try to do that.
I totally agree with everything Ken said. And it reminds me that I think there are two key ingredients to, so it's not just experience, right? The wisdom literature actually shows us that you can get very old and not have gained much wisdom. You can have the same kinds of experiences and it not result in changes that reflect wisdom gained. Okay. So it's not just having the experience, it's how you integrate that experience into your life. Now, and I think it's not just how you reflect on it, it's how you literally integrate it into your life. Allow it to change you for better or worse. And I think there are two really key ingredients to helping our students to both have these experiences and then allow these experiences to change them for the better, to really integrate them. One is to practice in this community, like Ken was talking about, of colleagues who, I think it was Meacham who talks about the wisdom atmosphere. And he defines that as an atmosphere where you can explore, where you can truly explore the decisions or actions you've taken, and that holds this space between paralyzing doubt and that one end of extreme humility, paralyzing doubt. We don't want a doctor who can't make the first incision, between paralyzing doubt and too confident knowing. So it's that space that you can explore, that you can get that middle way. So having that atmosphere for students to see and experience. And then secondly, having longitudinal relationships are important to learning this, to growing in this capacity for wisdom. And in particular, if you're going to be a doctor, a longitudinal relationship with a patient is where you can explore and learn. And that's a container in which, kind of like your family was when you were growing up, it's a container in which you can really learn these things that we're talking about, and reflect on the experiences that you're having and reflect on how a patient, moves through all the experiences in their life. Anyway, I think those two things are kind of key ingredients to helping students gain wisdom throughout their medical school careers. And then the last thing I'll say is that, how quickly we gain wisdom and change for the better also depends on how resistant we are to it. And what we can bring to it. So, kind of breaking down those. That's why I think adversity is such a potent, a potent place in which we can gain wisdom, because it does break down our resistances. It makes how we were before sometimes impossible. We have to explore and change. So, yeah.
Mark, I've I don't know if I'm jumping ahead here, but Peggy's triggering something very important in my mind now, which is reminding me of how she and I first met and started working together when she was using this abstract term, which I had no idea what it meant when I first heard it in the medical world, which is longitudinal. All right. It's such a dull word. But
True.
Never
thought of that, Ken.
My first real learning experience, and it was through this that I ultimately met Peggy, was when students of mine at Swarthmore ended up at medical school at the Cambridge Health Alliance in Boston and called me and asked me to come up and see if I could watch what was happening, because they said they finally understood some of the things that I was trying to teach. And I spent a few weeks up there just observing, shadowing people, and that program just very quickly, because Peggy actually has a more sophisticated version of this program, was a clerkship program. But instead of having the clerkship being people going into the hospital to shadow doctors as third-year students, the third years had a special program, and they were assigned every morning for the whole year to be in one of 4 clinics, one Monday, one Tuesday, one Thursday, and one Friday, with family doctors that specialized in psychology or pediatric care or general medicine. And they followed and mentored those doctors to the point where after a few weeks, they started doing the interviews and started giving care under the doctor's guidance, and then would have discussions where the doctor would then come in front of the patient, talk to the student about what the student had seen and not seen. And they got this extraordinary longitudinal mentoring. Each student in general or family medicine would have 15 patients that would be their patients for the whole year. Every time those patients came into the hospital, their buzzer would go off. The students would leave whatever class they were in, and they would accompany their patient, right? And then they would discuss it with their doctor. So it broke down the normal third year system into an incredible learning experience. And then Peggy took a version of that idea, which I would like her to explain, because she built it into all 4 years, the first 4 years of the medical school at UVA. Just say something about that, Peggy, because
Yeah, so we took what it's really not that bold a step, but it is bold for a medical
it's
school.
bold.
It's bold to match a patient or family with a medical student from day one of their medical school, and they carry that relationship all the way through all 4 years. And when you think about it, I mean, simple examples of what that built in the students, that perspective taking. Okay, now it's not a patient that they're meeting that they've met once. This is their patient that they've known for 3 years. And when a physician, if they go to clinic with them, they would go to the OR. If they were having a procedure, they would, they did everything they possibly could with that patient, home visits, the whole thing. So they really got to know them, and they came to love them. We don't talk about love enough.
We don't.
But when you love a patient,
Yeah.
it matters more.
Yeah.
What happens to them? It matters more when a clinician in the room isn't listening to the patient, or the patient doesn't understand what that clinician is saying. The decisions that are made, they have more breadth of an understanding of what it means to this human being to have a surgery or not. They know the family and how that process is going to affect their lives. I don't know how you get that perspective as easily as you can get it when you have a longitudinal relationship. It shows you the side of medicine that we always want our physicians to keep in mind, but it's very hard to keep that in mind if you've never had that experience. The only thing you can draw on is perhaps a family member who was a patient. But I think for a young clinician to have had that experience really does set the groundwork for them to be able to do all these things, and to have the motivation, if you will, to be a compassionate doctor.
Though Peggy's not saying it, that program was so successful after she ran it for 4 years with groups going through first, second, third, and fourth year medical school, with a lot of people very wondering and quizzical about what the hell she was doing. The program worked so well that it now got it adopted as the standard program for all the medical students at UVA Medical School. So it was a design that worked. It's kind of a proof of concept, and then it spread to the entire medical school. So it wasn't just this particular doctor. It was actually Peggy and her husband Jim. It wasn't just these two doctors that were doing that. It was now the whole school. But that's kind of an example. It's also, although she wouldn't say, it's kind of an example of the practical wisdom of Peggy, right? Of figuring out how you're going to redesign education by actually starting at a small scale, figuring out what works and doesn't work, and then proof of concept, spreading the idea. So now you're changing the structure, right, of 4 years of medical school. So you're designing for wisdom in that sense.
Designing for wisdom. That's a powerful concept. So we've been talking a lot about the classroom space. I'm wondering if we could take it into the practice space for a moment. One of the participants has reflected on the concept of both sort of self-reflection that is required for practical wisdom, but then also the communal aspect. I think, Peggy, you said earlier, practice in a community of colleagues. And the question in the inquiry perhaps is, how does one create that sort of environment or context? And what does one do when they find that others may not be open to the type of dialogue or practice that better facilitates wisdom?
Becky, you're going to be the expert on this one.
I can take a stab at that. There are hundreds of ways, I would say, literally. Well, I haven't counted.
Encouraging.
There are a lot of ways. And it's things that are on the hoof, and it's things that are placed structurally. But I think whatever you can put in place that allows either quick moments of reflection or opportunities for deeper reflection, you're never going to go wrong. We don't have enough time for that. And I want to get to the anti-wisdom things, because the way that medicine has been broken down and pushed by shorter and shorter and shorter time frames and fewer and fewer opportunities to both reflect together and even reflect on our own, and certainly with the patient, those are anti-wisdom forces that we need to be attentive to and resist. I just did a seminar for residents about coping with error. Actually, it was about talking to patients and families after an adverse event that was related to a medical error. And one of the ideas, I asked the question, do you all ever get together? Do you get together on a regular basis to just ask the question, was that the right thing that we did? And could we have done it better? Or why did that go so well? And the residents, well, they have a quarterly Q&A, a quarterly quality review, right?
Mm-hmm.
It isn't this kind of weekly or even daily practice of what happened yesterday and how did that go? And how could we have done it better? And did we do the best job? And if so, what made it go so well? That is building in opportunities for reflection and the mindset of being open, not just being open to, but actually seeking out ways of doing things differently or better that help people to grow more quickly. So the residents came up with the idea, actually, of doing a weekly 10 minutes after their usual regular resident meeting, 10 minutes on what went well this week, what could we have done better? To create that kind of constant sense of curiosity about how are we doing, how can we learn from each other? And I was so proud. That was just wonderful. It wasn't my idea, it was theirs. It was great.
Can I give another example, Kimara?
Please, Ken.
Peggy's examples are great because she actually did them. I only observed them. This is an example at Dartmouth Hitchcock Hospital in the palliative care service. They have, as part of their once a week, as part of their 1 hour kind of morning briefings, the 4 or 5 doctors, the half a dozen plus nurses, some of the volunteers, the aides, fellows, all sit down for a 1 hour meeting every morning before they go see patients, in which they talk about the patients they're going to see and what they've learned, which itself is pretty amazing. But on Wednesdays, they carve out about half hour, 45 minutes to something they actually call Wisdom Wednesdays, right? And the way, did I make that? Did I make that?
Zoom was
No, okay.
celebrating Wisdom Wednesdays, Ken. That was pretty
That was
spectacular.
pretty good, huh? The way Wisdom Wednesdays work is that a team of 2 doctors, or it could be doctors and a nurse or nurse practitioner, make a presentation of a difficult case they are currently working on. And they do a differential diagnosis of the case, where someone goes to the whiteboard and takes notes while they make the presentation. And the presentations always follow more or less the same pattern, which is the 2 docs are present to the team what they knew when they were called in, when the palliative care service was called in to see a patient. What were they told before they went in the door to see the patient? And then the group of about 20 that's sitting there is asked, if you were told that, what would you think you would find? And how would you react? Right? There's a couple of minutes on that. Okay. Then the second stage is they turn the handle and open the door and walk in and talk to the patient. All right. And they're told what it is that they see and hear. And then it switches back to the whole group. They don't say what they did or what they prescribe or what action. It's what would you do in this particular case? They're just giving them the facts now that they see, not what the doctor saw, but what they saw. They're asked what would they do, and there's often very hot debate about this, which covers everything from emotions and caring to technical stuff that needs to be done in terms of how you're going to handle this. There's real debate about it. And then the doctors talk about what it is that they did, right? And then the third question is, what was the consequence of that? And they again ask the group what they think the consequence of this would be, and the group discusses this. So you're actually using the actual, and sometimes the live case, although you're not in the room with the patients, you're actually using the live case to get reflection and deliberation and critique. But instead of critiquing what they did, they're actually asked to imagine what it is that they would, what it is that, and it encourages a kind of deliberation, reflection mindset in a fairly safe environment in order to do it. So that's an example of designing for wisdom, of a kind of structure. It's exactly what Peggy was doing, but instead of the 10-minute version, it's an hour version, and instead of with residents, it's with the whole team. So it's kind of an example of how you can design for wisdom.
I love that idea of that concept of imagining and wondering. It takes away maybe the barb of critique that can sometimes be there, and allows us to just perhaps open a bit to the adjacent possible, or some of the other things that might be there. So, Peggy, you used the term anti-wisdom practices, and that you wanted to get to some of that a little bit. So let's do that. Let's walk into that space, and tell us a little bit about maybe starting with your perspective, as you look at the profession of medicine, what are some of the anti-wisdom practices that you see, or things that you've encountered?
So I think the probably the one that rises to the top of every list that I've gotten from everyone in medicine, top of the list is time. That this capacity for deliberation and reflection, the capacity for forming relationships, all takes time. And so time constraints is one of our I think it's one of our strongest anti-wisdom forces. Now, right alongside that, what's happened in medicine is this two things. One is the widgetization of medicine. So humans aren't widgets. This isn't a factory line. And standardization is good, but in patient safety, we know that standardization is not everything. And in wisdom practice, standardization, unfortunately, or widgetization, I should say, really allows dehumanization of our practice. And that to me, that's anti-wisdom right there. So, and then separation is tough too. So as we get farther and farther from less and less proximate to the patient, we suffer from, we and the patient both suffer from that separation. It's harder to make good contextual decisions. It's harder to understand what the best decision would be when we lose context, essentially, when we lose proximity. So, and you know, the ultimate proximity is the house call, right? That's where you really get to see and understand the context of this human life. Now you can get that in the hospital, but it's harder. And it's almost impossible to get it in a 5-minute clinic visit of someone you've met once. So time constraints, separation rather than proximity, and widgetization, by which I kind of mean the one size fits all. Yeah, I think are three really important, well, that's four, sorry. Well, no, it's three. Important anti-wisdom forces that once you identify them, then, you know, think about, is there a way to, first of all, is it important to change those? Because, and can we do the kind of medicine we want to do if we don't change them? You know, the patient safety movement has successfully been able to use the phrase, it's unsafe, in order to get significant changes in how we practice that are for the betterment of, for the better. Why can't we say it is unwise to practice this way? Anyway, that's what I've started to say. I've become more militant in my old age, in a good way. Less accepting of the argument against these changes, recognizing that there are forces, not the wisdom forces, the unwise, the anti-wisdom forces. They have certain value. You know, it's making money, it's keeping solvent, it's whatever. But if they're not countered by anything, they will take over. And I think that's partly what's happened.
And anything you wanted to add to that?
No, except that if we're talking about structural change and designing, then looking at about how bureaucracies themselves work just as bureaucracies, and looking at how the financial models work and the reimbursement models work, and trying to figure out either how to work within those, how to carve out space within those, or how to change those against forces that are actually far beyond the forces inside of any medical institution. They become very important, and I think that's how many doctors ultimately become political activists, in terms of wanting to see those changes. But I think it's what Peggy's saying is very important and very realistic. We can't be naive about the structural constraints that Medicare, Medicaid requirements, the things that lead to 20-minute visits, the ways that you, the way that reimbursement structures work. Peggy's talked to me sometimes about the ways in which doctor-patient alliances often can create the power to bring about change, but that's not something that many doctors look for. I don't know if you wanted to say a few words about that, Peggy, but that's a critical piece if you actually think about the fact that you need to create new structures and designs to allow character and virtue and practical wisdom to flourish.
I think what Ken is referring to, and this is something that I've gotten more and more convinced of, that somehow the widgetization and the businessification, if that's a word, the time constraints, all of these forces have somehow succeeded in many cases in separating the doctor or the clinician from the patient, driving a wedge between them as though we want different things. My experience of my husband has ALS, and so we've been very much in the being a patient and family member mode recently. And I got so frustrated by the simple changes that would make things better for patients that the staff had been advocating for, but the administration just wasn't listening. And I'm like, okay, this is stupid. And we got a patient family advisory committee together where patients, families, and staff and faculty are all on the committee. And they are all identifying things that need to be changed and then working to change them together. And so when we approach a problem together and go to admin, they can't do that. They can't separate us. We are on the same side of this issue. And it's been extraordinarily effective. I don't think people want necessarily to pit us against each other. It's just that's how the forces tend to work if left on their own. And so if there's any way that we can ask the question, how do we get on the same side here? Because my experience is we almost always want the same thing. Yeah. Patients want more time with us. We want more time with patients. Patients want a relationship with us. We want to be able to have that. They want continuity. There are all these things that we all want the same thing, and we're all miserable. So let's get on the same side, and that's, I think, where our power is to really create some structural change. Anyway, it's been very empowering for us as patients and family members, and also for the staff. I've been really it was quite surprising to me, actually, how much it meant to the doctors and the nurses and the therapists and everyone to be able to literally work together on some of these like crazy making problems.
It's really powerful. You've given us many practical examples this afternoon, I think, in terms of how to actually live this out. It's tough to argue with wisdom or practical wisdom and wanting to grow in that. And I think at times these anti-wisdom practices or the forces within the system can make it feel as though one is has lost such ability to exercise these practices within that. I think it can feel hopeless. And so it is beautiful to hear some examples of how this can happen. And I am curious, we have just a few minutes left in our time together. And so I think my question to both of you would be to give us sort of that sense of the hope or what can be done when it feels as though the rules perhaps are aligned against us practicing wisdom.
So I'll say one sentence and then Ken, you can, because
Sure.
you're
Say
much
more than
better at
one.
wrapping up. What I like to teach my residents is if there's a rule that doesn't make sense, you kind of feel free to ask 3 questions. Who made the rule? So like who is kind of in charge of this rule? What's the rule trying to achieve? So what's the underlying reason? Because if you're going to change something, you're going to have to address that reason. And then is there a different way of approaching this that that makes more sense? So people often understand, they know when a rule doesn't make sense or a structure isn't making sense, it isn't serving anyone. So giving the house staff the permission to ask that question, wait a second, we made these structures, we meaning humans, made these structures, we made the rules. That means they can be changed.
The first research that I did at the hospital, at Dartmouth Hitchcock Hospital, that I started in about 2009, 2010, was exactly on this puzzle, which I was curious. My original curiosity, for example, about palliative care was, where did palliative care come from? Not the idea. I knew it came from hospice, but how in the bowels of this institution that's such a bureaucracy and has got to look at its bottom line and it's so controlled by the government, how did you actually create a medical service there that was into care, not cure? And was, how did this happen? And writing, and to do that, I started interviewing people starting back who were there from the 1980s on. And what I found, without going through the details, was that it was ultimately a fascinating coalition organized initially by nurses, who then brought in people in psychology and oncology, who then brought in people from the community, including the Visiting Nurses Association, and who brought in patients, and who then themselves found a benefactor in the area who was willing to put up some of the money. And that enabled them it was really a 20-year struggle to convince the administration in the hospital to create a service that had not existed before. Now it's become more common in other hospitals, but it was actually a struggle, and it was a bottom-up struggle. And I still remember one of the nurses, Marie Bakaitis, who was actually influential in this. I remember when she said to me this great insight. She said, it's exactly when a doctor says to a patient, there's nothing else we can do, that there's everything we can do. And this motivated her to actually, her and some others, to mobilize a coalition that actually created the palliative care service. It's exactly the kind of alliance that Peggy is talking about, and it brought about a transformation, which has not taken over the entire hospital, certainly, but now is there and teaching other people in the hospital. But it does demand that kind of organization. And I think that that's critical, and it's not something a lot of people who are busy taking care of patients have the time and energy to work, to be fair to them. It's that kind of exercise of power against the anti-wisdom powers that actually can make a difference. And you see my political science background kind of coming out through the cracks. But yes, I think Peggy's exactly right.
Thank you. Well, I have said this to the two of you before, but I often reflect on these moments in my life where I felt like I've gotten to sit at the feet of wise teachers. And every time I am with the two of you, I come away with more thought, more reflection, more challenge, and more realization of just how worthwhile the struggle is to continue to move towards wise practices, and the charge that I believe we all have as leaders, believing that we all have leaders in spaces that we influence, to be both modeling this and also to make sure that where we have the opportunity to influence against these anti-wisdom practices, that we are reflecting and asking those questions. And I would say certainly as we look at the Kern National Network as a movement, my hope is that we all will be able to continue to come together to bring the right type of pressure and force to the systems of which we are a part, so that hopefully, Peggy, at some point we could hear, no, we can't do that because that's unwise. It would be unwise,
That would be
unwise to practice that way. So absolutely. Well, again, thank you. You have given us such depth of thought and practical examples. We are so grateful to both of you, and we're grateful to all of you who joined us this afternoon and took time to engage in the conversation, to learn. We also would like to extend our thanks to the Kern Family Foundation, whose support makes the work of the KNN possible. If you are feeling energized to integrate practical wisdom and other foundational concepts into your setting, we invite you to continue to engage with the KNN. There are many ways to get involved, not the least of which is becoming a member of the movement. Grounded in change theory, our membership offers teams and organizations a pathway and support for activating systemic transformation within your environment. Members commit and contribute to advancing flourishing and applying framework concepts, and at the same time gain guidance, support, and resources to move the work forward. In fact, as part of today's session, members are invited to join us in just a moment for some additional time with our experts. We'll be opening the breakout room shortly, so members, do please stay on the line for an opportunity to speak with Ken and Peggy. Thank you again all for participating. We really hope to see you for our next session, which is going to be on May 6th. During that session, Drs. Tyler Vanderweel, Matt Lee, and William Pearson will close out our series with a session focused on flourishing in medicine. It will be a great time. Have a wonderful evening, everyone, and we'll look forward to seeing you again on May 6th, if not before.